Good morning to all the respected faculty and my dear students present over here. Uh, Today we, the group of first of the seminar, are here to present on the topic metabolic disorders. In this topic we are going to cover the points diabetes, obesity, PCOS. Then we are also covering the hyperlipidemia and the causes, treatments, and some research papers published on this topic. Here are the group members of our topic. So let's begin with the first topic, that is diabetes mellitus. So diabetes mellitus, in this we will first discuss the introduction, then types of diabetes, and to understand the types of diabetes we need two important topics, that is glucose homeostasis and insulin resistance. So first of all, diabetes is nothing but a metabolic disorder in which a glucose level in the blood is increased due to absolute or relative insulin resistance. Absolute is in the case of type 1 and relative in the case of type 2. Absolute means whatever that you can clearly see that this level is increasing. Relative means the symptoms are not visible, but it is happening in a what you can say apparent fashion. It is a very common clinical condition, and you might have means everyone's family members have this. Means most of the family members suffer from this disease. Next, symptoms of this disease include fatigue, weight loss, frequent urination, and blood vision. But as I said, diabetes is very prevalent in our society. More than 10% of the population suffers from this disease. As you can see in the graph, the cases of the diabetes are increasing over day by day. And this is due to our sedentary lifestyle, and we are limiting our physical activity, and other causes like obesity and hypertension are also contribution in these increasing cases. Also, the age group of 50, above the age group of 50, 1/5 of the total population which is above the age group of 50 suffers from this disease, which is a very high number. So we also, and most of these cases are undiagnosed. That is over half of these diabetes cases are undiagnosed, and this can be and more in the case of India. As you can see, India is the second second at the second place in the number of cases of the diabetes. First is China, and you can see the proportional undiagnosed in case of the India is almost equal to China. That is, in the case means I think it is indicating that we don't have proper diagnostic measures, or we are not taking the proper measures to educate the society about the diagnosis of diabetes, because we know that early diagnosis can also can be a crucial key factor in curing this disease. As I said, increasing the type 2 diabetes is due to 4 factors, that is urbanization, aging population, decreasing levels of our physical exercise, and obesity and overweight. Now let's discuss the topic type of diabetes. There are 3 main types of diabetes. First is type 1 diabetes, second is type 2 diabetes, and third is gestational diabetes mellitus. Type 1 is insulin dependent, type 2 is non-insulin dependent, and gestational develops during pregnancy after the birth of the first child. In this case, the mother does not have diabetes, but the chances of developing type 2 diabetes is increased in her further life. So before getting into the details of the types of diabetes, we need to understand what is glucose homeostasis and insulin resistance. So first, that is glucose homeostasis. Glucose homeostasis is nothing but the process by which the normal glucose level is maintained in our blood by various hormonal and chemical mechanisms. So the main hormones involved in this are glucagon and insulin. So when when the blood glucose level is low in our blood, a negative feedback is given to our body, which leads to release of glucagon from the pancreatic cells of the pancreatic cells, which glucagon is a hyperglycemic hormone which increases the blood glucose level in the blood, which restores the normal level of the glucose. And in the opposite case, when the blood glucose level is high, negative feedback is given to the pancreatic cells, which pancreatic cells and beta cells, which release insulin, and insulin then is a hypoglycemic hormone, which reduces the blood glucose level back to the normal. So how does this happen? Glucagon is responsible for 3 things, that is gluconeogenesis, that is formation of glucose from lipids, proteins, glycogenolysis, that is breakdown of glycogen into glucose, and it also inhibits glycolysis, so that the blood concentration of glucose is increased, and opposite of this is performed by insulin, which is responsible for lowering the glucose level. As you can see in this chart, the hyperglycemic factors, that is absorption from GIT, that is absorption of glucose from small intestine to the blood, and glycogenolysis, that is breakdown of glycogen to glucose in the liver, and gluconeogenesis, that is formation of glucose from other compounds like lipids, proteins, are the factors which contribute to increasing the blood glucose level. And this glycolysis, glycogen synthesis, and lipogenesis are the factors which remove the glucose from the blood, and the factors which perform the removal of glucose are known as hypoglycemic hormones, that is insulin, and the opposite of that is hyperglycemic hormones, that is glucagon, cortisols, growth hormone, and ACTH, which increase the plasma glucose level. The plasma glucose level normal is 70 to 110, and the postprandial level, that is the level after 2 hours of having a good meal, is less than 140 milligram per deciliter. Now the next topic is insulin resistance. Insulin resistance is nothing but our receptors are not responsive to the formation of insulin. That is, insulin is being produced normally by the pancreatic cells, but the role of a hormone is to send a message, transport of glucose into the blood. This message is not being sent to the respective receptors. So insulin resistance, first of all, it leads to three things, that is ineffective glucose uptake, increased insulin production, and development of hyperglycemia. Ineffective glucose uptake leads to a deficiency of glucose in the blood, which again performs negative feedback, as I said, gives negative feedback, which leads to increased production of insulin. And we know that insulin resistance is not due to the deficiency of insulin. Insulin is produced in normal amount, but still glucose level is low. So the negative feedback leads to increased insulin production, and to the point the pancreas can only produce insulin to a maximum point, or you can say a saturation point. And when the saturation point is reached, we start developing symptoms of the type 2 diabetes, because the increased insulin cannot cope up with the demand for the glucose. This is primarily occurs due to the malfunction of GLUT4 receptors, which are responsible for transport of glucose into the blood. The cells affected include muscle cells, fat cells, and liver cells. Insulin resistance, as I said, is a gradual process. So that means the symptoms of this disease, or you can say symptoms of this disorder, are not visible in the earlier stages, because, as I said, first of all, it is not due to the low insulin levels. It is due to the malfunction of receptors. So the symptoms are not visible in the early stage, because negative feedback is given to the pancreas to increase more insulin, but this is up to a certain stage. After that, the increased insulin cannot cope up with the increased glucose demand, and in this primarily the receptors are affected. So means it does not matter if you give more insulin to the body, the receptors are not responding to the insulin. Now, with this knowledge, we can finally differentiate between the type 1 and type 2 diabetes. The cause of type 1 diabetes is a decreased insulin production due to the destruction of the beta cells of the pancreas, while the cause of type 2 diabetes is insulin resistance, as I said. In this, insulin is being produced, but it is not, but the receptors are unable to transfer the message of insulin to the required organs. The prevalence, as I said, is type 2 is more prevalent than type 1. The onset of type 1 diabetes is childhood or puberty, and type 2 diabetes is 35 years. Type 2 diabetes often goes unnoticed till 40 or 50 years due to the less prevalent symptoms in the early stages. Like I said, the symptoms develop rapidly in the case of type 1. The ketosis is more common in type 1 diabetes, because the insulin hormone is responsible for inhibiting lipolysis. But when the insulin is deficient, the lipolysis process increases, which leads to formation of ketone bodies, and more chances of ketosis in the type 1 diabetes. GLUT4 receptor, as I said, type 1 diabetes it is functional, type 2 diabetes it is not functional, and the treatment of type 1 diabetes is easy, or you can say is easier and clear. That is, we have to give artificial insulin or insulin therapy. But type 2 diabetes, we have to change our lifestyle, like obesity. We have to eliminate the causes like obesity, hypertension, and we have to have a balanced diet to treat this disease. Thank you, all of you. The next details will be presented by my friends.
Diabetes too. Good morning everyone. My name is Shrikala Navnathfad. My roll number is 69. So I will be explaining metabolic dearrangement, clinical representation, acute complications and chronic complications of diabetes mellitus. So first we will start with metabolic dearrangements. As we know, the level of insulin hormone is decreased in diabetes mellitus. So the effects of insulin on carbohydrate, lipids and proteins are reversed in diabetes mellitus. Decrease in the level of insulin will cause hyperglycemia, ketoacidosis and hypertriglyceridemia. The common symptoms are in clinical representations. Common symptoms are glycosuria, polyuria and polydiphysis, polyphagia, weight loss, fatigue, weakness, blurred vision, chronic recurrent infections. Chronic recurrent infections and poor wound healing. So let's start with acute complications. First is diabetic ketoacidosis, in which the insulin doesn't the body doesn't produce enough insulin, so the use of blood sugar level for energy can't happen, because therefore the liver breakdowns fats for the energy production, which cause the accumulation of ketone bodies in our blood. It makes it more acidic. Normal level of ketone bodies in blood are less than 1 milligram per deciliter. Only a trace amount of ketone bodies are found in urine, which are undetectable generally in usual tests. So it can lead to ketonemia, ketouresis and smell of acetone in breath. Ketouresis is presence of ketone bodies in urine, and ketonemia is high level of ketone bodies in blood. Next is hyperosmotic non-ketotic coma. It happens due to high level of glucose level, in which osmolality of extracellular fluid is increases, in which the person is which will cause to osmodiuresis, leading to water and electronic duplication. Hydration of cerebral cells due to hypotonicity of extracellular fluid results in coma. In lactic acidosis, lactic acidosis happens due to overproduction of or underutilization of lactic acids. Overproduction happens because of increased rate of anabolic glycolysis, and underutilization can happen due to impairment of CTA cycle. Chronic complications consist of vascular diseases. If atherosclerosis happens in medium-sized vessel, it can lead to plaque formation and consequent intravascular thrombosis. And if it happens in cerebral vessels, it can lead to paralysis, and if it happens in chronic arteries, it can lead to myocardial infections, and in small vessels, it can lead to microangiopathy, in which endothelial cells and mural cells are damaged, which result in diabetic retinopathy and neuropathy. Next are complications in eyes. It consists of cataract formation in lens and retinal microvascular abnormality. In cataract formation, there is increased rate of sabital formation. It happens due to there is excessive glucose in lens, which is converted to sorbitol by the endolase reductase enzyme, which leads to the formation of a cloudy layer on the lens of the eyes, which can cause blurry vision. Next is retinal microvascular abnormality, in which the delicate blood vessels of retina are damaged. Next is neuropathy, in which peripheral nervous system is affected. It can cause due to decreased glucose utilization of or conversion of sorbitol in um, conversion of it to sorbitol. It can lead to sensation loss, pain, weakness and numbness and tingling in more than one parts of the body. And last is the diabetes complication. And it diabetic mothers tends to have bigger babies, and you must be thinking why this happens, because the high level of diabetes of mother is transferred to the fetus during the pregnancy, and this causes the baby's body to produce more insulin to use the excessive glucose, which will lead to the deposition of tissues and fats in his body. So there are high chances of abortion, premature birth and uterine death in fetus. Thank you.
How to move slide. Good morning everyone. I am Sivanandan Prasad and I am going to talk about management of diabetes mellitus and its mechanism. So let's move forward. Here we can see that there are many anti-hyperglycemic drugs that are available in markets. These drugs act at different sites of our body. These may be brain, adipose tissue, skeletal muscles, pancreatic cell, pancreatic alpha cells, gut, kidney and liver. Then if we come, there is a class of drugs that is alpha glucosidase inhibitors. What does it do? Basically, it inhibits the absorption of glucose from the small intestine. Here we can see in the first figure that in the duodenum part there is a more reabsorption of glucose, and without the acarbose, that is the example of AGIS. With acarbose we can see that there is a less absorption of glucose and it more goes towards the fecus. These are the examples of the AGIS. Then we come to another class of drugs, that is sulfonyl urease. Basically it will lead to stimulate the secretion of glucose from the pancreatic beta cells. But when the glucose enters the pancreatic beta cell, then it will get metabolized and it will lead to the production of the ATP. This increased concentration of ATP and the sulfonyl urease drugs. Sulfonyl urease drugs will bind to the sulfonyl urease receptors and increase ATP, and this binding will lead to the closure of the ATP sensitive potassium channels. Then what will happen? Potassium concentration will increase inside the cell. This leads to the depolarization of the membrane, and this leads to the opening of the voltage gated calcium channels. This leads to the rapid influx of the calcium channels, and this calcium, what does it do? Increased concentration of calcium inside the cell will lead to activation of the enzyme protein kinase, that will lead to the exocytosis of the insulin from the cell. So these are the examples of the sulfonyl urease. Then we move to another class of drugs, that is DPP4 inhibitors. DPP4 means dipeptide peptidase. What is the DP4? DP4 enzyme. Firstly, we will come to know that DP4 enzymes destroy the incretins, that is GLP-1 and GIP are the incretins, and this incretins, what does it do? It stimulates the insulin release and inhibits the glucagon release. Then we have to block the DP4 enzyme. Then we will use DP4 inhibitors to block these enzymes. This will lead to the saving of the incretins, and it stimulates the insulin release and inhibit the glucagon release. This will lead to the lowering of blood glucose. These are the examples of the DP4 inhibitors. Then move forward, we come to another class of drugs, that is metformin. It basically does that, it decreases the hepatic glucose production, and it also decreases the reabsorption of glucose from the intestine, and also increasing the uptake and utilization by the peripheral tissue organs. Here we can see that metformin acts on the liver. This will lead to the increase of the AMPK. What is the activated protein kinase? This activated AMPK leads to the decrease of the SREBP, that is estrogen regulatory element binding protein, and it also leads to the decrease of the PE, PCK and glucose 6-phosphate. This decrease of glucose 6-phosphate will lead to the decrease of the gluconeogenesis, that will lead to the lowering of the insulin resistance. And decrease of the SRBP leads to the decreased fatty acid synthesis, and it will also lead to the decreased fatty liver. Then metformin also acts on the skeletal muscles, and it will lead to the increase of the AMPK, that is activated protein kinase. This will lead to the increase of the translocation of group 4, and this will also lead to glucose uptake. This will reduce the insulin resistance. These are the examples. Metformin. Sorry. Then we move another class of drugs, that is glanites. It has a similar mechanism as the sulfonyl urease. It also basically inhibit the potassium efflux. This will lead to the depolarization of the membrane, and it will lead to calcium influx, and that will lead to the insulin secretion by the activation of a kinase. We come to another class of drugs, that is TZD. What does it do? Basically, it acts on the skeletal muscles and increases the glucose uptake. So it will lead to decrease of the hyperglycemia. TZD also acts on the liver. It will decrease the gluconeogenesis. That also leads to the decrease of the hyperglycemia. It also acts on the adipose tissue, and it will lead to increase the fatty acid uptake and increase of the lipogenesis. And it also leads to increase glucose uptake. That will lead to the decreased plasma free fatty acids. That will lead to the increased glucose uptake in the skeletal muscles, and that will lead to the decrease of the gluconeogenesis in the liver. These are the examples of the TZD. Then we move to another class of drugs, that is SGLT2 inhibitors. Basically, what does it do? In the kidney, we all know that most of the approx 100% glucose reabsorbed in the PCT, proximal convoluted tubules, and that is by the 90% of glucose is reabsorbed in proximal to PCT, and 10% in the distal part of the PCT by the SGLT1, and 90% by SGLT2. Basically, normal glucose reabsorption is greater than 180 gram per day. After, then we will, what does we do? That we will block the SGLT2 proteins by the SGLT inhibitors. That is the examples are here. Then what, after inhibition of SGLT2, protein glucose reabsorption decreases to SGLT2 proteins. Glucose reabsorption decreases to 100 to 130 gram per day. Urinary glucose excretion increases to 50 to 80 gram per day. These are examples of the SGLT2 inhibitors. Then we here are, then currently the treatment for diabetes mellitus is progressed by a stem cell transplantation. This is a new innovative treatment of diabetes, and it seems that for type 1 diabetes it is much more close to the treatment, and for type 2 it is lesser, but in the future it will be noticed that the stem cell transplant will be more purposeful to treatment in the diabetes mellitus. So all the theories are prescribed from the ICMR and WHO. These are the links. Thank you all. Thank you.
So, good morning everyone. I am Mukul Sakre, roll number 60. Today I am going to discuss on a metabolic disorder, that is obesity. So, basically, starting with what actually obesity is. In our day to day life, we find many people around us suffering from this complex disorder. So, according to WHO, obesity can be defined as a chronic complex disease defined by excessive fat deposit that can impair health. So, how do we quantify obesity? So, there is a body mass index, as we are familiar with it. Body mass index over 25 is considered to be overweight, and over 30 is considered to be obese. The complications of obesity are that it could lead to increased risk of type 2 diabetes and heart disease. It can also affect bone health, reproduction, and increase the risk of certain cancers. So the rates of overweight and obese people continue to grow in adult and children. So this can be justified by the statistics. I have taken this chart from a very trusted source. So what we can observe that over a span, the data collected in this chart is from 1999 till 2018. So in about 20 years, what we can observe is that obesity rates as a percentage has gone up from 30.5% to 42.4%, whereas severe obesity has gone up from 4.7 to 9.2%. That is actually double in just 20 years. So, moving forwards, there are many inherited physiological and environmental factors combined with diet, physical activity, and exercise choices which affect obesity. But the topic which I am going to discuss today is hormones influencing obesity. So, basically, there are many hormones which influence the activity, which influence the accumulation of fat in the body. But specifically, I will be talking about these four hormones, that is leptin, ghrelin, which is also called the hunger hormone, cortisol, which is also called the stress hormone, and insulin. So leptin is a hormone released by the fat cells that signals the brain to reduce appetite and increase energy expenditure. Ghrelin, as from the name we can suggest that it is produced in the stomach, signals the brain, and it makes us feel hungry. Cortisol, which is a stress hormone which is produced in the adrenal cortex, that can cause excessive weight gain if the levels are too high. Fourth one, that is the insulin, is a hormone secreted by pancreas that helps regulate blood sugar and energy balance. Insulin level after eating a meal increase, and they basically interact with the brain and reduce food intake. So basically, what all common things we can observe from here is that the site of action of all these hormones is the brain. Now let us try to understand the mechanism of these, specifically these two hormones, that is ghrelin and leptin. So ghrelin is basically secreted from the stomach. It gives positive feedback to the AGRP neuron. So what is this AGRP neuron? AGRP neuron is orexigenic agouti related protein neuron. So these are basically located in the brain, specifically in the hypothalamus and the brainstem. Uh, as we all know, nuclei are specialized neurons which secrete chemicals. So AGRP neuron are those neurons which secrete AGRP. So on the action, the ghrelin gives positive feedback to the AGRP neuron, which further inhibits the activity of satiety neuron, which increases feeding and increases our food intake. On the other hand, we can find that leptin, which is secreted by adipose tissue, gives a positive feedback to POMC neuron. So what is this POMC neuron? Anorexigenic pro-melanocortin containing neuron. So this leptin gives positive feedback to POMC neuron, which secretes alpha melanocyte stimulating hormone that binds with the melanocortin 4 receptors on the satiety neuron, which increases satiety and reduces food intake. So what we can understand from this mechanism is that ghrelin and leptin both are antagonistic to each other. So this is the normal physiological conditions, but imbalance in the levels of these two hormones can lead to accumulation of fat. So when we talk about imbalance in these hormones, we'll first talk about hypoleptinemia and its cause. Basically, hypoleptinemia is a very rare disorder to have. The main condition associated with low leptin levels is congenital leptin deficiency, which is a genetic condition that prevents adipose tissue from producing leptin. So as we know that leptin is responsible for increasing satiety, low level of leptin can give us constant food seeking behavior, due to which a person can be severely obese. It will have impaired satiety and intensive hyperphagia. Next, talking about leptin resistance. So it's basically associated with hyperleptinemia, that is excessive levels of leptin. So as we know that leptin is involved in increasing satiety, so increase in leptin levels should reduce the hunger pangs, but it is observed that obese individuals had higher serum leptin levels and adipocyte LEP mRNA content. So this is okay, but still the body weight reducing effects of leptin were not significant. So what can be understood from this experiment is that the obese individuals had developed leptin resistance due to defect in leptin transport across the blood-brain barrier or the intracellular signaling mechanism downstream of the leptin receptors. So these imbalance can cause obesity. Thank you.
Okay, so good morning everyone. So Mukul very well introduced and explained the topic of obesity to you, and I'm Savarnik from Group 1, and I will be dealing with a very niche subcategory of obesity known as obesity-induced adipose tissue fibrosis. Now the name is quite big, but it is actually quite an easy topic, and I will try to make it so for all of you. So these are the contents of my discussion. If we can look at the photo first, A shows you a normal adipose tissue, which is seen under the slides as we all have seen already in the histology practicals. And on the right side, we have an adipose tissue that has undergone fibrosis. Now there we will see the fibrosis, and these are actually certain sites known as the crown-like sites, the CLSs. Now those will be discussed later, but it is important to pay attention to them right now. Now I will be introducing adipose tissue to you. I will then be going on to the main topic of my discussion, which is a cellular interplace involving the adipose tissue fibrosis. I will be dealing with them very moderately right now. Then I will be discussing the clinical correlations. Now these clinical correlations will already have been discussed or will be discussed further by my colleagues. So I will not get into detail to them, and the treatment methods will be followed up by Didwar after me. So I will not get into them either. So introduction. Now what was the origin of the adipose tissue? The adipose tissue is actually a tissue which stores fat in the body. Over the course of evolution, it was decided by the multicellular organisms that there must be some mechanism that we need to store the excess nutrients that we get. Those excess nutrients are actually present in our body because of an imbalance between the caloric intake and the energy expenditure, which burns those calories. Now that was a time where there was a lot of mobile lifestyle, people were nomads, they were hunting, but nowadays there is a more sedentary lifestyle, there is more of an inclination towards that. So what happened because of that is obesity results, and because of obesity there are certain signaling pathways, there are certain cellular interplays which cause the extracellular matrix accumulation, and that extracellular matrix accumulation is known as the adipose tissue fibrosis. Now the adipose tissue is basically divided into two types in our body, the white adipose tissue and the brown or beige adipose tissue. It was first thought that the brown adipose tissue is only present in babies and certain mammals which undergo hibernation. But very recently it has been discovered that those brown adipose tissue is also found in adult humans, but we will not get into that. And the predominant adipose tissue in our body are the white adipose tissues, which are involved with all the energy homeostasis. Okay, so the underlying cellular interplays. Now, as we can see in the diagram here, we have fibroblasts, which through certain mechanisms turn into differentiated myofibroblasts. These myofibroblasts are the actually key drivers of the organic fibrosis. So, the main topics I will be discussing in this are the myofibroblasts. Then I will be discussing the TGF beta superfamily, the TGF standing for transformation growth factors. So, we can see in the diagram here, the cell going from protomyofibroblast to differentiated okay. Yeah. Acha, point. Okay. From the cell going from protomyofibroblast to differentiated myofibroblast, there are certain TGF beta 1s. These are actually chemicals which are part of the TGF beta superfamily, which we will discuss. Now, the excess of nutrients in our body, which are present due to a sedentary lifestyle and excess of caloric intake, they manifest themselves in the form of the generation and the proliferation of myofibroblasts. Now, we've all read the NCRT, the growth wala chapter. In that chapter, we have discussed that growth is of two types: the increase in the size of the cells and increase in the number of the cells. The increase in size is known as the adipose tissue hypertrophy, and the increase in number is known as the adipocyte hyperplasia. Now, in the normal mechanisms of the body, adipocyte hyperplasia is more preferred over adipocyte hypertrophy. So, to discuss the hyperplasia, we obviously have to discuss the progenitor cells. We have to discuss where the mature adipocytes come from. And for that, we study the precursor cells, the APCs, adipose tissue progenitor cells. And for that, we delineated a particular group of cells which express this PPAR gamma. Now, PPAR gamma was already discussed by Shivnandan in his topic about TZDs. These PPARYs are actually certain transcription factors present in the genome, and what they do is they induce adipose tissue differentiation. So, when we did this, Friedman and his group actually did this. We will not get into their experiments. Their experiments showed that there was certain heterogeneous group of progenitors. What does heterogeneous mean? Heterogeneous meant that even though they were progenitors which were contributing towards the same pathway, they were forming adipocytes, but there were certain clear demarcations between them and what they expressed. Now, this is all very factual. This is all, you don't have to get too much into this. You just have to focus on the colored slides. Now, the hallmark of myofibroblast, why they do this fibrosis, is that they have an increased production of extracellular matrix components, which are written there. And now let's get into the TGF beta superfamily. TGF, as I discussed, stands for transformation growth factors. These TGF beta superfamily consists of TGF beta 1 ligands, and it consists of activin A ligands. What that does is it binds with certain receptors, the TGF beta receptors, which are of two types, TGF beta R1 and TGF beta R2. Now, they are not specific single receptors. The TGF beta R1 family consists of 7 receptors, and the TGF beta R2 family consists of 5 receptors. But the receptors that TGF beta 1 and activin A bind to are known as the ALK5 and the TGF beta R2. So, what they do when they bind is they activate certain pro-fibrotic genes which induce the formation of collagens, ECM remodeling enzymes such as matrix myeloproteineases, and integrins, proteoglycans, and CTGFs, which further contribute to this fibrosis. The main topics, however, are the PDGFR alpha expressing progenitors and the PPAR gammas. The PPAR gammas, they inhibit adipose tissue fibrosis because they carry more of the progenitor cells towards adipose tissue formation, and the PDGFR standing for plant-derived growth factor regulators. They were actually initially thought that they would only contribute towards adipose tissue differentiation and form the adipocytes. But it has now been discovered that they actually also are the main contributors to this ECM production. And so because of those 2 points, we can obviously correlate this with the fact that the deletion of PPAR gammas or the activation of PDGFR alpha plus will increase the fibrotic transformation of wide adipose tissues. Now, this is a diagram I was discussing. We can see that these adipocyte precursors are actually common precursors. The exact pathway has not been found, and that's why there's a question mark there. But these adipocyte precursors will form adipocytes and they will form the myofibroblasts. Through certain experiments, it is seen that when this TGFR beta family does its work, more cells go towards this myofibroblast pathway, and that is why there is a fibrosis. This is known as the phenotypic switch. This is the diagram showing that the function of the TGF beta superfamily. These TGFR2s and the activin A's, they will bind with the TGFR beta R2 receptors. This binding will cause a phosphorylation cascade. This cascade will further call the TGF beta R1 receptors, which are ALK5s in this case, and that will form the phosphorylation cascade, which will invite the SMAD2 and the SMAD3 receptors, the SMAD4 receptors, and together they will form a complex that goes to the genome and it inhibits the production of PPAR gamma, which, like I discussed, will enhance the adipose tissue fibrosis. This is because since the main function of the PPAR gamma was to induce the adipose tissue differentiation, there will not be differentiation anymore and more cells will go towards the fibrosis stage. Now we go towards the clinical correlations. Like I discussed previously, the adipocytes undergo hyperplasia more predominantly over hypertrophy. This is because hypertrophy usually leads to certain cells which are malformed. These malformed cells will go into necrosis, and it has been found that these necrotic adipocytes they secrete certain pro-inflammatory adipokines like the tumor necrosis factor alpha, the interleukin 6, interleukin 8, and so on and so forth. These pro-inflammatory adipokines will actually increase the risk of cardiovascular diseases. Cardiovascular diseases will be dealt with further by Manav Khatri. And now we will talk about insulin resistance, which has already been talked about by Siddhant. Insulin resistance has been correlated in a very vast sense by the obesity. These are the crown-like sites I was discussing earlier. These are actually the sites where the interaction between the macrophages and adipocytes in an adipose tissue take place. So these sites are said to be, these are shown to be increased in the adipose tissue undergoing fibrosis, and it increases the insulin resistance. Now these treatment methods are very brief. Obviously, since the TGF beta antibodies were the main, TGF beta family was the main part in all of this, we can induce certain anti-TGF beta antibodies that will prevent this fibrosis, or at least it will alleviate the person of all this. The treatment methods will be dealt with further by Didwar. I thank you all for your time. इसको long press करना तब आएगा. तेरा अच्छा हाँ ठीक है कहाँ है ओके ऑल द बेस्ट.
So, good morning everyone. My name is Didva. Am I audible? My name is Didva. I would be presenting on some basic pharmacological treatments for weight loss. A particular drug which I am going to talk about is semaglutide. So, before discussing that, a simple effect that would lead to a great influential treatment for diabetes in coming future, which is a great influential treatment now, is incretin effect. This simple effect will lead to a treatment method. So this simple incretin effect is simply, we can understand from this diagram, is that oral glucose elicits more insulin release on the pancreas than IV glucose. So this suggests that there is some extra factor that influences the release of glucose, influences the release of insulin from the pancreas other than the blood glucose concentration in the blood. So this effect is called incretin, and today only GIP1 and GIP1 and GLP1 are the factors that that fulfill the definition of this incretin hormone, and this incretin effect is very useful in further treatments of diabetes. So GLP1 receptor agonists are just external chemicals that mimic the action of GLP1 in our body. So this GLP1 receptor agonists have been used effective treatments for diabetes for last decade, and recently these has been used for weight loss purposes also. Some of the GLP1 receptor agonists are semaglutides and these other chemicals. So to understand the action of GLP1, the major sites of action is in the pancreas, where it stimulates the insulin secretion, and the brain, where it increases the satiety and in the stomach, where it increases the it decreases the gastric emptying and thereby increasing the satiety. So now let's understand how it increases the insulin production in the pancreas. So this is a basic diagram of pancreatic beta cells. As we all know, it releases insulin, and the basic physiology is that it has potassium channels. At rest stage these are open, and these are calcium channels, which at rest stage are closed. So when glucose comes inside the cell and ATP are generated from respiration, this ATP will affect the ATP sensitive potassium channels, and which leads to their closure, and thereby the concentration of potassium inside the cell will increase. This will lead to the depolarization of the membrane and thereby opening the voltage gated calcium channels. Now as these calcium channels are more outside along, they will move along the concentration gradient inside the cell, thereby increasing the intracellular concentration of the calcium, which leads to the exocytosis of this vesicle, which contains insulin and C-peptide in the blood. This C-peptide is very important for the diagnostic purposes of the diabetes, differential diagnosis of the diabetes, and this C-peptide will be excreted from the kidneys as urine as it is, and as we all know, insulin will affect the tissues and it will help them increase the uptake of the glucose and thereby decreasing the glucose level in the blood. Now where GLP-1 comes in is that this pancreatic beta cells has GLP-1 receptors on it, and this GLP-1 stimulates this GLP-1 receptors, and which further stimulates the closing of the potassium channels and the opening of the calcium channels. This further increases the intracellular concentration of calcium inside the cell, which further increases the exocytosis and thereby increasing the insulin in the blood. So as Shananal already discussed about the DPP-4 inhibitors, this basically inhibits the natural GLP-1 in our system. So these basically destroy them, which leads to the decrease in the insulin in the blood. Now if we give some external chemicals which mimic the action of this GLP-1, which are GLP-1 agonists, this will stimulate the GLP-1 receptors, and which will further increase the intracellular calcium ion concentration by opening the calcium channels, which will further increase the exocytosis of the vesicles and thus increase the insulin in the blood, which will be very helpful for diabetic patients for maintaining their glucose levels. So just in the case of insulin decreases the blood glucose level. So this is the basic method how it helps in decreasing the blood glucose levels in a diabetic patient. So now let's understand how it helps in decreasing the feeling of hunger in us, and this is a basic centers in the hypothalamus which makes us feel hungry and makes us feel satious, as Mukul already discussed. So there is a arcuate nucleus inside the hypothalamus, and this is controlled by two groups of neurons, orexigenic neurons and anoxigenic neurons, which orexigenic neurons stimulate this NPY receptor in the arcuate nucleus in the hypothalamus, which increases the appetite, and anoxigenic neurons decreases the appetite. This is a basic concept. So now these orexigenic and anorexigenic neurons are further further stimulated by some peripheral peptides that are secreted by stomach, duodenum or GI tract, adipose tissue, and pancreas. As he already discussed, leptin, insulin, and ghrelin. So these again inhibit and promote these neurons, and thereby affecting the sense of appetite. So this GLP-1 and some other chemicals that are secreted by the GI tract will inhibit the orexigenic neurons, and thereby inhibit the sense of appetite, sense of hunger, and thereby decrease the food intake. This GIP-1, which is secreted by the duodenum majorly, inhibits the orexigenic neuron basically. So if we give semaglutides, which is just a GLP-1 receptor agonist, which affect just like GLP-1, will also decrease the effects of orexigenic neuron, thereby inhibiting them and thereby decreasing the food intake. Also it activates the orexigenic neurons and orexigenic neurons, which will further help in decreasing the appetite. This is the basic how it helps in decreasing the appetite, and this is the major contributor in weight loss. Majorly, all the weight loss that is seen in the studies is due to this action in the brain and how it reduces the appetite. So the last effect, that is how it affects the stomach. As you all know, there is, when food comes inside the stomach, there are gastromechaноreceptors which get activated on stretching, and this makes us feel satious, which thereby decreases the food intake. But when the food comes outside the stomach, which is called gastric emptying, this gastric emptying will lead to the deactivation of these mechanoreceptors and thus makes us feel more hungry. So this GLP-1 will affect the gastric emptying and will decrease the gastric emptying, and thereby increasing the gastromechanic receptors for a longer time, and thereby makes us feel more satious for a longer time. So this is also a method how it helps us not feel hungry for longer. So this is the basic three steps. There are many secondary effects of this drug also, that it is shown to decrease the insulin resistance in many patients, and also liver diseases. It helps in liver diseases. So this was a clinical trial to check the efficacy of the drug. So this research was published in New England Journal of Medicine in 2021, in which this many patients, obese patients without diabetes, were given 2.4 milligram of subcutaneous semaglutide, and the effect was contrasted with the placebo effect, the placebo group, that the control group. So the placebo group had only around 2% decrease in the body weight from the baseline, and the semaglutide treatment group had about 16% decrease in the weight. So this difference was quite good for the drug, which led to its use in weight loss. And thank you everyone for this slide. The purpose of my slide was to show you that how a simple effect, a simple reaction in our body can lead to such great drugs which helps us treat such common diseases. So these are my resources, and thank you everyone. Thank you, Ashwin sir.
इसको लॉन्ग प्रेस से
अरे इसको कैसे लगा?
लॉन्ग प्रेस
इसको लगा मेरे इसमें।
लॉन्ग प्रेस से ये करो लॉन्ग प्रेस ये लोग लॉन्ग प्रेस
So good morning everyone, I'm Gauranshi, and today the metabolic disorder that I am discussing is polycystic ovarian syndrome. So the contents I'll be covering are what is PCOS and the difference between PCOS and PCOD, which is a common confusion between a lot of people. Then the difference between normal ovary and a PCOS ovary. Then the etiology and pathogenesis. So we'll be starting with what is actually PCOS. So it is an endometabolic disorder with ovarian expression of the metabolic disturbances. The clinical features may include obesity, insulin resistance, hirsutism, etc. And here you can see an ultrasound, which is a diagnostic measure for PCOS. So in an ultrasound, we see multiple small cysts of size less than 1 centimeter, which is a characteristic feature of PCOS. Then the difference between PCOD, that is polycystic ovarian disorder, and PCOS, that is polycystic ovarian syndrome. So when we talk about PCOD, it occurs due to the ovaries releasing immature eggs, that is leading to hormonal imbalances and swollen ovaries, while PCOS is occurring due to metabolic disturbances that are leading to excess androgen production from the ovaries, and that is leading to the formation of cyst and insulin resistance. Now talking about the severity, so PCOD is quite less severe than PCOS, while in PCOS we see heart diseases development and also diabetes, and it can also lead to infertility. And talking about fertility, the PCOD women do not usually require medical assistance to conceive, while the women with PCOS have a problem in conceiving, and it is considered as a leading cause of infertility due to ovulatory dysfunction. Now, the difference between a normal ovary and a PCOS ovary. So, a PCOS ovary is quite enlarged. The volume is more than 10 ml. The normal volume of ovary is 3 to 6 ml, so it is quite large. Then talking about the follicles, so follicles in the normal ovary are 5 to 10 follicles per ovary, but when we talk about a PCOS ovary, the follicles are quite reduced in the size, and they are more in number. There are more than 12 ovaries, there are more than 12 follicles that we see in a single ovary. So talking about the cysts, very rarely we see cysts in normal ovaries, and they too are functional. But when you talk about PCOS ovaries, we can see very large number of small immature cysts, which are arranged in a string of pearls pattern. Then hormone production. So the hormone production by normal ovary is normal. There's no imbalance in that. But talking about a PCOS ovary, the androgen secretion is quite excess, and the ratio of estrogen and progesterone is imbalanced. Also, the ovulation and menses. So when we talk about ovulation, it is irregular or it can be completely absent in a PCOS ovary. That is known as anovulation. And the menses are also irregular. It can be completely absent. That is amenorrhea. And the appearance on an ultrasound. So when we see ultrasound of a normal ovary, it is completely smooth. But when we see a PCOS ovaries ultrasound, we see small clustered cysts and the stroma is quite thickened. So the etiology, that is the cause of PCOS, how it is happening. So there is no particular confirmed theory of how it is actually happening, but there are some theories that have been discussed. So one theory can include ovaries as the primary site of endocrinal changes that is leading to the development of PCOS. And in PCOS, the LH is quite raised. LH level is raised, and the LH-FSH ratio, which in a normal person is 1, here it is 2. And it is a very common disorder that we can see in adolescent girls. 5 to 15% of adolescent girls are having PCOS. Also, women of reproductive age, which are suffering from hirsutism or insulin resistance, infertility, are seen to have PCOS. Also, other theories include genetic, familial, or environmental factors as the etiological factors of PCOS. So, when we talk about genetic factors, this gene mutation of CYP21 gene is one factor that we can consider. Another is familial occurrence, that is happening due to sex-linked autosomal dominant inheritance of the gene. Also, enhanced gene phosphorylation activity in the ovary that is leading to hyperandrogenism, and the reduced insulin receptor activity, which is leading to peripheral insulin resistance, lead to the development of PCOS. Also, obesity can be considered as a cause. The adipose tissue in a body is the endocrine immunomodulatory organ. So when we talk about adipose tissue, it is releasing leptin, adenokines, with different cytokines, which is interfering with the insulin signaling pathway in the liver and muscles. So it leads to the peripheral insulin resistance development, which further leads to the development of PCOS. Also, when mothers are having PCOS or they are obese, their adolescent daughters tend to develop PCOS. So in short, we can describe the etiology as the genetic and environmental factors are leading to insulin excess, and they also lead to reproductive abnormalities and metabolic abnormalities. And insulin excess can also lead to metabolic and reproductive abnormalities, and they collectively lead to the development of PCOS. Also, PCOS can also lead to reproductive and metabolic abnormalities, and it can lead to insulin excess. So these things are interlinked. Like PCOS can also cause obesity, and obesity can also cause PCOS. Also, due to insulin excess, the LH levels in the body are raised, and because of that, immature oocyte formation occurs, and miscarriages and infertility are common in women with PCOS. So these are the references that I have used, and thank you. What's the problem? My ear. Or if you want to use the pointer, this is the pointer. Okay. For the rest. Good morning, everyone. So, my name is Priyanshi Agrawal, roll number 74. The basic introduction about PCOS along with its etiology and pathogenesis has been very well explained by Gauranshi. So, here I am explaining the endocrinological changes, along with that, the pathology of PCOS, along with some treatments, as there is no cure of PCOS, but there are some medications that can be helpful along with some lifestyle changes. Other than that, I would like to talk about the role of microbiome in PCOS and their differences. So if I talk about the endocrinological disorders or changes, what happens is basically there is polycystic ovary. So it happens, there is increased testosterone level. That means there is hyperandrogenism. That means there is increased level of androgens in the body. Also, there is large secretion of LH by the pituitary gland, thereby increased LH by FSH ratio. Also, there is hyperinsulinemia that happens because of the insulin resistance taking place in the body. And because of the increased insulin level, there is a decreased level of SHBG. Basically, SHBG is sex hormone binding globulin, and it can all lead to the testosterone increased level and the liver. The decreased secretion of SHBG can lead to hirsutism. Hirsutism is basically the male-like pattern of body hair in the women that is found in the women with PCOS. Along with that, there is impaired ovarian function, like ovary, there is anovulation. There is no ovulation taking place in the ovary.
So because of that, there is irregular menstrual cycles that happen, or there may be amenorrhea or complete amenorrhea that can take place. Along with that, there are multiple cysts that can be seen, easily diagnosed in the ultrasound, and they are peripherally located like a string. Along with that, the hormonal imbalance takes place. Increased level of testosterone and decreased level of the women hormones, basically the estrogen and progesterone. There is estrogen dominance. Along with that, there is a low level of progesterone that is present in the body, and it can all lead to various symptoms that happen in a woman, PCOS, like infertility and everything. Also, there is increased risk of metabolic syndrome. Like PCOS is completely linked with every other thing that happens in the body. It can lead to obesity and weight gain, and it can also lead to type 2 diabetes. So it is very harmful for the body. So in this diagram, yeah. So basically, this is the polycystic ovary, and it happens because of the basically everything is interlinked. Like estrogen, testosterone level increases, so LH level also increases, and because of the increase in LH level, there is increase in the testosterone level. So this is a complete cycle that takes place. Then, if I like to talk about the pathology, so again, the ovarian dysfunction, there are polycystic ovaries, like it may be a single ovary or both the ovaries that may be in this condition. Also, there are follicular arrest. That means the small follicles are seen, and there is no maturation of the follicles. So there is basically no secondary oocyte that forms in the body, or if it forms, it just get stuck there only. So there is no menstruation that takes place. The ovarian structure changes, like ovaries get enlarged. It can be seen in a surgical process that they swell up, and also a thick white capsule of tunica albuginea that forms around it. Also, the ovarian surface may be lobulated. So ovaries are well destroyed in PCOS. This is the same thing that happens here, the increased adipose tissue. Basically, because of all this, there is a difficulty in losing weight in PCOS. So if I talk about the treatment, as I said earlier, that there is no cure of PCOS, like still there is a research is going on for the treatment, but there are some medications and some lifestyle changes, some yogasans that can help with the women. Basically, the aims of the treatment is to cure women with menstrual disorders. Like there is no menstrual cycle, or it may be irregular, it may be like very less bleeding that takes place. Also, it is to treat the hirsutism and infertility, because there is a problem in conceiving if a woman is diagnosed with PCOS. That is not a problem in PCOD. So here's a treatment targeting the insulin resistance and hyperinsulinemia. So the first drug that I'd like to talk about is metformin. So basically, metformin is an insulin sensitizer that improves the insulin action in the peripheral tissues. And because of the increased insulin action, there is a decreasing level of insulin levels, and thereby there is a decrease in the ovarian androgen production. And because of that, there is the cause of hyperinsulinemia. Along with that, the hyperandrogenism can be cured. It also improves the glucose uptake by increasing the activity of this AMP activated protein kinase pathway. So the next drug is thiazidines, that is TZDs. These drugs include the picloglitazone, which activate the peroxisome proliferator activated receptor gamma, that is PPAR gamma. What it does, it improves the insulin sensitivity in the adipose tissue, muscle, and liver. Also, that decreases the circulating insulin levels and improves the glucose metabolism. So there's a cure of hyperinsulinemia. Also, the last drug is the inositol. It includes the myoinositol and D-chiroinositol. These are the insulin sensitizing agents that acts by improving the insulin signaling pathway and the function of the phosphatidylcholine inositol 3 kinase pathway. So this all drugs can be helpful in curing the hyperinsulinemia and the insulin resistance in the women. Along with that, the next treatment is for hyperandrogenism. It includes the combined oral contraceptives. Combined oral contraceptives, what it does is it suppresses the gonadotropin released from the pituitary, and thereby it suppresses the main hormone, is the luteinizing hormone from the ovary, from the pituitary basically, which stimulates the production of androgens from the ovarian theca cells. So because of the suppression of the gonadotropin release, there is a decrease in the level of luteinizing hormone, and because of that, there is no androgen secretion from the ovarian theca cells. So the anti-androgens are spironolactone, flutamide, and finasteride. Basically, spironolactone blocks the androgen receptor, and because of the blockage, it prevents the androgen from exerting their effect at the target tissues. So because even after the increased level of androgens, they cannot affect the tissues. Flutamide is a non-steroidal androgen receptor blocker. It again does the same thing as like spironolactone, but it is non-steroidal. It inhibits the action of androgens in the peripheral tissues. Finasteride is a 5-alpha reductase inhibitor that blocks the conversion of testosterone to dihydrotestosterone, that the more potent form of testosterone basically. It is more harmful. GnRH analogs की बात करें अगर तो it is gonadotropin releasing hormone analogs which reduces the LH and FSH secretion through the downregulation of GnRH receptors, and therefore it decreases the ratio. Then this is the role of microbiome in PCOS. If I talk about the microbiome diversity, it is often seen that women with PCOS may have a reduced gut microbiome diversity, and it can adversely impact their metabolic health. There is inflammation, and imbalanced microbiome can contribute to systemic inflammation that is often seen in the women with PCOS, and it can further improve or exacerbate the insulin resistance in the women and further leading to hyperinsulinemia. If I talk about the metabolism in such women, the gut microbiome is involved in metabolism of nutrients, carbohydrates, and some hormones. Because of the alteration, the body processes of the carbohydrate and fat gets impacted or affected, which influence the weight gain and insulin sensitivity, and thereby causing all such symptoms that happen in a woman with PCOS. So here in this figure, it is being seen that everything is interconnected. Like because of PCOS, insulin resistance happen, and then everything like microbiome is affected in the body. Hormone regulation, the microbiome may also influence the estrogen metabolism. So it can further lead to the hormonal imbalance that takes place. Dietary interventions. If a woman with PCOS consumes something that has a increased fiber in it, then it can also the probiotics it has, then it may manage the symptoms of PCOS. Overall, while the exact mechanism are still being studied, there is still research is going on about this topic. But yeah, there's a complex relationship with PCOS with the microbiome. And with that, lastly, I would like to tell that there is no such awareness about PCOS in the world. Like about 70% women of the world are still suffering from PCOS, but they are not diagnosed right now. About 5 to 15% are diagnosed, and they are getting the treatments or the basically to reduce the symptoms. These are the references, and yeah, thank you.
Good morning, everyone. I'm Tanish Gupta, and today I will be presenting on hyperlipidemia. So these are the topics which we will be covering: definition and a difference between two commonly used terms, hyperlipidemia and dyslipidemia. Characterization of hyperlipidemia, its types, causes, clinical presentations, and diagnosis and treatment. First, the very first definition is hyperlipidemia is basically an increase in the amount of lipids in the blood. As we can see in the two figures, that in the second figure there is mixed hyperlipidemia in which cholesterol is clogged in the blood vessels. Hyperlipidemia and dyslipidemia has a very narrow difference. Hyperlipidemia is basically an increase in the amount of lipids in the blood, while dyslipidemia is an imbalance between the good and the bad cholesterol, irrespective of their without being either out of range. Next is the characterization. In hyperlipidemia, triglycerides and cholesterols get increased and their level become greater than 1.5 millimole per liter. In case of very low density lipoproteins, VLDLs, they increase up to 30 milligram per deciliter. LDLs increase up to 130 milligram per deciliter, and apolipoprotein B increases to 1.2 gram per liter. High density lipoprotein get decreased in this case, which becomes less than 40 milligram per deciliter. Next is the types. So on the basis of origin, it is of two types, primary and secondary. Primary is basically of genetic cause due to any mutation in the receptor genes, while secondary is because of any other factor like diabetes mellitus, nephrotic syndrome, which my colleague Utkarsh will be covering. On the basis of type of lipid elevated, it can be of hypercholesterolemia and hypertriglyceridemia, in which triglyceride increase and cholesterol increase. Combined, in case of combined, both the cholesterol and the triglyceride level increases. Also, an elevation in the level of lipoprotein can also be classified as hyperlipidemia. On the basis of cause, the primary cause is the genetic cause, and the secondary causes can be for increase of triglyceride, it can be chronic renal failure, acromegaly, alcoholism, diabetes mellitus, and obesity. While increase in cholesterol can be because of Cushing syndrome, growth hormone deficiency, nephrotic syndrome, and hypothyroidism. There are the clinical presentation. The general presentation will be the patient will be asymptomatic for many years before the disease is clinically evident. And when the disease becomes clinically evident, some of the symptoms which can be seen is the abdominal obesity, increased blood pressure, prothrombic state, and pro-inflammatory state. Symptoms can be which the patient present will be palpitation, sweating, anxiety, shortness of breath, difficulty with speech and movement. Signs, in case of signs, which we can identify as pancreatitis, eruptive xanthomonas, peripheral polyneuropathy, and the body mass index will be greater than 30. In case of laboratory test, there will be an elevation in the total cholesterol, triglyceride, apolipoprotein B, and the C reactive proteins, and a high level of LDL and VLDL. These are the physical signs of hyperlipidemia. First is the xanthomata tuberosa, which I shown here. Next is the xanthilesma palpebrarum, in which plaques of cholesterol occurs. Corneal arcus, in which around the retina cholesterol gets deposited around the cornea. Treatments. So the non-pharmacological treatment is a healthy diet, and the pharmacological treatment can be various anti-hyperlipidemic drugs like HMG coenzyme A reductase inhibitors, fibrates, cholesterol absorption inhibitors, and the most common and the cheapest treatment is a niacin. In this niacin inhibits the conversion of triacyl glycerol into fatty acid in the adipose tissue, and this fatty acid is not formed, so it does not get transported into the liver, where it does not lead to a secretion of VLDLs, and further it does not cause the hyperlipidemia. And that's what it is a potent inhibitor of lipolysis in adipose tissue. Since LDLs are also derived from VLDLs, so it also decreases. These are some of the sources from which I have taken, and thank you.
मेरे को देख
वो किससे चलता है वो पॉइंटर इससे चलता है उत्कर्ष मोरवाल ठीक है याद रखिए
Good morning. My name is Utkarsh Morwal. I am here to represent the topic biochemical basis of hyperlipidemia. As Tanish told you about the hyperlipidemia, I will extend the topic and give some introduction about biochemical basis, and later on we will discuss on mechanism in familial hyperlipidemia, nephrotic syndrome, and diabetes mellitus. The biochemical basis involves are cholesterol metabolism, lipid transport, triglyceride metabolism, genetic factors, hormone influences, diet and lifestyle, liver function. In triglyceride metabolism, if there is an increased level of triglyceride, it is all referred to hyperlipidemia. Let us see the mechanism of hyperlipidemia in various disorders. The first one is familial hyperlipidemia. Familial hyperlipidemia is also known as familial hypercholesterolemia. In this case, genetic mutation affects the lipid metabolism. So before coming to the abnormal condition, let us see a normal condition. This is a receptor, low density lipoprotein receptor, which is present on the plasma membrane of hepatocyte. It binds with the low density lipoprotein and form a complex ligand receptor complex, which is internalized by a factor. Low density lipoprotein receptor associate protein. Once the internalization occurs, PCSK9 acts on it and dissociate it so that LDL release in the hepatocyte and it is further degraded in lysosome. These receptors are synthesized in the ER and maturation occurs in the Golgi apparatus, and when the PCSK9 acts on this complex, some LDL receptors are degraded and some are recycled. And the next one is nephrotic syndrome. Nephrotic syndrome is a one of the most common kidney disease, which means loss of plasma protein in urine. In nephrotic syndrome, because of the hepatic compensation mechanism, PCSK9 is increased, and because of PCSK9 increased level, LDLR decreases, so that LDL will not able to come inside the hepatocyte. This is the mechanism. In nephrotic syndrome, PCSK9 increases. This lead to LDLR deficiency. Hepatic uptake of LDL decreases, and because of this hepatic compensation mechanism, hepatic ACAT also increases, which has a function that it converts the intracellular free cholesterol into cholesterol, which will release in the blood, and in both cases there is increased LDL cholesterol level. The next one is diabetes mellitus. Hypertriglyceridemia is the most common lipid abnormality in diabetic population. In diabetes mellitus, there is a condition, insulin resistance, which means that the cells of muscles and liver will not able to respond to insulin, and because of insulin level relative to insulin level glucagon level is increased, which stimulates the glycogen breakdown and start gluconeogenesis, releasing glucose and fatty acid in the blood. Because of the insulin resistance, a hormone sensitive lipase get active, and in the adipose tissue this convert triglyceride into fatty acid, which releases in the blood and goes to the liver, and in liver through DNL pathway this free fatty acid converted back to triglyceride, and this triglyceride converts into apolipoprotein B, and insulin resistance and apolipoprotein B activates MTP, which leads to the secretion of VLDL, and which further produce LDL relatively higher amount than HDL. These are some clinical manifestations of hyperlipidemia: premature cardiovascular xanthomonas. These are the skin lesions. Tendon xanthomonas, arcus salinus. As you can see, there is cholesterol deposition, and the family history of hyperlipidemia, cardiovascular disorders. These are the sources. Thank you.
presentation to काम करता चाहिए किसमें कहाँ है left right
Good morning. I am Manav, roll number 50, and I'll be addressing the elephant in the room today, cardiovascular diseases, and starting with some nerve-wracking facts about this disease. In comparing the scenario in India to the Western world, some facts are that in India, 2016 CVDs contributed to 28% of total deaths, compared with 15% in 1990. So it near about doubled. Also, these coronary artery obstruction and MI are the #1 killers in the world. According to WHO, India accounts for 1/5 of the total cases worldwide. And the most important concerning fact is that these CADs strike Indians a decade earlier than the Western population. So more specifically, I will be discussing about atherosclerosis, cardiac biomarkers, and onwards with some recent advancements in the treatment of atherosclerosis and myocardial infarction. So atherosclerosis, it is a topic which relates to those of my colleagues, as has been discussed in the portion on hyperlipidemia. It has a positive correlation with especially the cholesterol, and concerning with the LDL amount. So as can be seen in this figure, the LDL cholesterol degradation pathway is mainly to ApoB mediated receptor, but the thing which is of relevance here is the non-specific uptake by macrophages. These macrophages take up especially the oxidized LDL, and they get converted and distended into the foam cells in case there is excess of LDL in the blood, and which favors their deposits in the subintimal space. This starts the plaque formation in the arterial wall, and there is then obstruction of blood flow. This is the first stage of progression of the atherosclerosis, and these foam cells are the hallmark. These are the hallmark of the atherosclerotic process. The symptoms vary accordingly with which arteries are affected, and most often the cerebral arteries and the aorta and the coronary arteries are predominantly affected by this atherosclerotic process. Onwards to the stage 2. This stage is important, as up until this stage, if the lipid levels are lower, especially LDL levels, then the arterial changes are reversible. However, if the lesion progresses unchecked, then the arterial changes become irreversible. The stage 3 is the fibrous proliferation stage. There is a definite component of inflammation involved in atherosclerosis, which continually raises the HSCRP and other phase reactants in the blood, which form the basis of the risk predictors in the cardiac biomarkers, as will be discussed later. And there is fibrous deposition and also glycosaminoglycans due to the growth factors liberated by macrophages and platelets. Stage 4 is the advancing fibrous plaque stage, as can be seen in this figure. This is the angiograph of a normal artery cross section and of a atherosclerosis affected artery. Now onwards to the cardiac biomarkers, the biochemical aspect of diagnosis of this disease. These have become the staple tests in the diagnosis of early diagnosis of myocardial ischemia MI, because it has become a protocol that the patient reports to the ER room with the symptoms. It has become a protocol to assay the biomarkers at the reporting time, 3 hours, 6 hours and 12 hours, because they can detect the ischemia at the earliest even before the ischemic changes are noticed in the ECG. And accordingly, we have two types of biomarkers, and those for the acute coronary syndrome resulting from the infarction, and those the risk factors. These are for detecting the ischemia, and these are for those people who have not had yet incidents of adverse cardiac event but can have in the future. So their HSCRP level and lipid profile will be accordingly dealt with. A biomarker is defined as a naturally occurring molecule, gene or characteristic by which a particular pathological process or disease can be identified. This is to clear the definition. Onwards to the cardiac troponins. The cardiac troponins are the staple tests, and these are the specific biomarkers of infarction. The cardiac isoform is specific for cardiac muscle, which resides 95% in the myofibrils and 5% is cytoplasmic. The importance of this fact is that, as can be seen in this figure, even in the small MI case, the troponin levels are initially increased. This initial increase is due to this cytoplasmic component, which is 5%, and the continual increased amount is due to the release from the myofibrils. This form the basis that the cardiac biomarkers and especially the troponins are good for the tests even after a long range of time of the incidence of MI, as can be seen here. Also, another marker is creatine kinase isoenzymes, but the thing with those is that they are also raised in muscle injury, but the troponins are specific markers for myocardial infarction. And in that too, the troponins can be CTNI, that is the I subunit of the troponin, or CTNT, the T subunit. The different reference levels are quoted here. For the CTNI, the reference level is 0 to 0.4 nanogram per milliliters, and for CTNT, it is 0 to 0.1 nanogram per milliliter. And these are the specific times within which they can be tested, raised within 4 hours after the onsets of myocardial ischemia, and this raises after 6 hours. And this is the point that I mentioned earlier, that CKMB is maybe elevated in muscle injury also, but these troponins are the specific markers for myocardial infarction. Then onwards to some recent advancements for the treatment of atherosclerosis. These are in addition to the conventional treatment of angioplasty and other surgical interventions. In the last 2 decades, there was preclinical testing of novel methods of drug delivery through nanomedicine, which target the structure and function of HDL, the phagocytic activities of macrophages, immune cells as carriers of neurotherapeutics, and others targeted thrombosis, inflammation, adhesion molecules, or the extracellular matrix. So these have promised a novel cure for the disease. For myocardial infarction, there are humans have at least 3 different types of platelet ADP receptors which are implicated in platelet blood formation, which eventually occlude the artery in cases of cardiac adverse effects in atherosclerosis and MI. These platelet receptors are P2Y1, P2Y2 and P2X1. Inhibitors of these have been developed, showing promise in the prevention of MI and strokes. Also, advanced imaging techniques like cardiac MRI and CT are carried out for the offer a non-invasive window into the myocardium structure and function. These are my sources, and finally I would like to thank the entire biochemistry department, especially our mentor Dr. Ashwin sir. He guided and coached us through this, and have a nice day ahead. Thank you.
So can we have all of you on stage? And please call Raja for stopping the recording. And we will invite Ranu madam to do. And then if you have any questions, you can. He's not there. Stop.
ऐसे छोड़ दूँ कहाँ था इधर से स्टॉप से